Hi, I'm Sunir Garg. I'm professor of ophthalmology on the retina service at Wills Eye Hospital in Philadelphia. We're fortunate to do what we do. We take care of a lot of patients. We have a lot of really great technology and we have cool surgeries, but all of that can take a toll on our neck and our back. And as the American population gets older, a lot of us take care of more and more patients than we used to. And we know that the more repetitive you do something, the more chance you are of getting injured over time. And as a lot of us love what we do and want to practice for decades to come, helping to prevent injury early can allow us to continue to have very healthy, productive careers for decades to come. Our whole workflow is sort of not designed for any meaningful ergonomics. When you go into our clinics, we have computers that are set up that are generally 90 degrees away from where the patient is. So I'm trying to talk to the patient while typing at the keyboard, and I sort of do this quasi-squat, lean over, turning my neck thing, which is really stressful on the neck and the back. The slit lamps are often not very well designed for what we're doing either. And our patients are sort of sitting far back in a chair, and a lot of them are older and have trouble leaning forward, so then we end up having to hunch over towards them. The footrest where the patient's feet go can sometimes block our chairs from getting close enough to the patient, so lifting those up can be helpful. Maintaining a strict upright posture can be really helpful. In one of my exam rooms, I have tables that are large enough for me to put a sandwich and a cup of coffee on, and that's unnecessary space that forces me to be farther away from the patient. Then I have to lean forward and tilt my head back, all of which is ergonomically really stressful. In the operating room, it's a very similar type of a concern. One of my favorite chairs has a great cushion, but has a very wide skirt. So that sometimes hits my foot pedals, so then I have to stretch my legs farther. Maintaining an upright posture where the patient's head is close to my abdomen has been very helpful. And you want to have your oculars positioned so at least you're looking straight into them, or ideally a little bit downward. That helps to keep the neck in a more neutral position. So there's a lot of small things that happen, but when you do them dozens of times a day for years on end, they really do take a toll on the body. So in the operating room, one of the things that I'll stress to my trainees is it's kind of easy just to have the patient wheeled into the operating room. You bring the microscope down and then you adjust your body to fit the microscope in the patient position. But I think a better way of doing it is kind of reverse that. Put yourself in a position that's comfortable, set your chair up in a height that's good for you, put the pedals where you want them to be. Then the second thing I do is I bring the patient in and I make sure that their head is very close to the top of the bed or it's not hanging over. Sometimes I'll see the fellow where the patient's sort of 6 inches down on the bed, and that already then has to have everything shifted forward. And then once that's done, then I bring the microscope into position. So I try to make it more surgeon-centered rather than bed-centered, if you will. And that's been really helpful. There's still some challenges though in the operating room with people have different height and width sizes. The microscope is a one-size-fits-all kind of a procedure, which can make it quite challenging. I'm more mindful of how my head is when I'm doing indirect ophthalmoscopy. So if I'm doing a straight scleral buckle in the operating room, I'm trying to be more mindful of how my head position is. You can try to lift the bed up so the patient's eye height is higher. That can be helpful. Some of my colleagues use a chandelier-assisted buckle, so they're still using the microscope for that. And in the clinic, we know that sort of dangling your hand in front of the slit lamp, holding a lens, is really stressful on the neck and the back. So you can hang your fingers off the forehead rest, that can be helpful. But a better thing to do is to have a pad underneath your elbow to support the weight of your arm. That's really helpful as well. But a lot of it's going to require continuous engagement with our industry partners, the people who make this equipment, to help make it more friendly on our bodies. Because once we buy the slit lamp, you're going to use it for 30 or 40 years. So you really need to start working the life cycle of the product early to achieve those changes. But I think talking to our industry partners is really important. A lot of times these are developed by these really smart, very talented engineers, but they're perhaps testing out equipment for minutes at a time. They're not doing it 60 times a day, every day. And so our needs and how our bodies feel with repetitive use are perhaps different than people who are designing the equipment but aren't necessarily using it all the time. So I think that dialogue is very important. I think kind of vocalizing what helps and what's data driven is really helpful. There are ergonomic experts in other professions. We can start bringing them into the fold to rethink our workflow and our designs from the offices to the operating room. Most of us spend more time in the clinic than we do in the operating room, so the clinic ends up being a big issue. For me, the slit lamp continues to be a potential obstacle for good comfort. And having that upright posture is really helpful. So I'm mindful of where my stool is in relation to the patient. And having the patient move forward in the exam chair allows them to be more upright. They're more comfortable. That then allows me to be upright and closer to them, which I think makes it better for both of us.